Okay, so thank you. It's always great to be at this conference. So my talk is on MRI and patellofemoral instability. And I'll just touch on two major issues. One is on patellofemoral dislocation and then on patellofemoral tracking issues. Now the way I look at imaging when we look at patellofemoral instability, I look at it as the effects of a dislocation event. So when it happens, what gets damaged, the possible causes or predisposing things that could lead to dislocation, and then things that affect the treatment planning of dislocation. So this is what I teach most of our radiologists. This is the stepwise way you should think about it, and this is how you can probably word your conclusions to the reports as well. When you think of the anatomic structures that are relevant, it's the patella, the trochlea, the patellofemoral ligaments, patellar position in the craniocaudal plane, the TT-TG distance, and then rotation and alignment. The patella, the trochlea, and the patellofemoral ligaments are probably the most commonly affected structures. The trochlea, patellofemoral ligaments, patellar position, TT-TG distance, rotation, and alignment are probably involved more with the predisposing factors. And then finally, in terms of management, we're usually looking to manage the patellofemoral ligaments, patellar position, TT-TG distance, rotation, and alignment, and then sometimes the patellofemoral chondral lesion that arises from that, and as well as the trochlea. So when we think about the effects of a dislocation event, we think about the injury-related changes that would happen to the patella, the trochlea, and the patellofemoral ligaments. So if we think of the classic lateral patellofemoral dislocation event, you would have the patella slipping out of the trochlea groove laterally. You'll have an impaction injury on the medial aspect of the patella as well as the lateral aspect of the trochlea. And this would manifest most commonly on MRI as bone marrow edema in both these locations. This is kind of nice to know because I see a fair number of patients who come to me where the clinical history would say concern for ACL injury or knee dislocation. And so I think you're being able to identify these two kissing contusions is a good way to open up your mind to know this patient has had a patellar dislocation and not something else. Sometimes on a sagittal image, these can be slightly more difficult or subtle to find, but you can see here very clearly this bone marrow edema here, and this is very typically HSS, where we only do sagittal fat suppressed images, not axial ones. So this image is very unusual to see at HSS. Now, what are the things that you would see on the patellar side when somebody has a patellofemoral dislocation? You can see something like a patellar contusion, which is essentially just bright signal within the patellar cartilage, but there's no discrete defect. You can see a discrete osteochondral defect that comes and flakes off, or you can see a larger bony defect, which is, this is almost pure chondral, whereas this would be osteochondral. And sometimes in this case, on an X-ray, you might see a very slender flake of bone in the suprapatellar recess, and this is exactly what that is. So typically a contusion, you wouldn't do anything. A chondral defect, you might think about fixing, and an osteochondral defect, again, you might think about fixing and stabilizing depending upon how acutely it's occurred. Effects on the trochlea are typically going to be the translational bone marrow edema that you're going to see on the periphery of the trochlea, so lateral femoral condyle far periphery. Again, you can see these impactional bone marrow edema patterns. Again, for those of you who look at ACL injuries and think about that, the bone marrow edema for an ACL injury is going to be typically slightly more posterior, whereas the patellofemoral dislocation edema is a little bit more anterior here. And you'll have a corresponding edema pattern oftentimes on the medial aspect of the patella. Thinking about and moving on to the effects on the patellofemoral ligament itself. Now, I know we get a lot of phone calls where people want to know, is the patellofemoral ligament torn? Is it torn on the femoral side? Is it torn on the tibial side? Is there a bony avulsion? And I think for the vast majority of cases that we see, we don't actually see a tear of the patellofemoral ligament. It's something that has dislocated many, many times, which is when they show up to you, unless somebody's had a very acute dislocation event. And it's usually just a very thinned out and stretched looking patellofemoral ligament. Oftentimes something like this. Sometimes you would see it more thinned out towards the patellar side. Sometimes you'll see a more discrete discontinuity in the midsection. And then sometimes you would see more thinned out towards the femoral side. Sometimes in somebody who's had a more acute or violent dislocation event, you'll see a bony avulsion, and that bony avulsion can obviously come from the medial patellar side. We seldom see a bony avulsion on the femoral side, and this is a sort of relatively unusual one where you actually see somebody who avulsed off and you can see the avulsion is actually from the lateral patellar facet. So just a variety of appearances that one could see, but I think the key thing to drive home here is that in a vast majority of cases where we see recurrent patellofemoral dislocations, we won't actually see discontinuity of the ligament or the retinaculum. We'll just see a sort of stretched and attenuated appearance. And actually, more interestingly, is if you look at a bunch of normals, it does look that way oftentimes as well. So it's sometimes difficult for us to tell on that. From some technical perspectives on an MR standpoint, oftentimes a lot of people do axial fat suppressed sequences which make all of these structures dark, and it's very difficult to differentiate the ligament from the adjacent fat. So we normally do non-fat suppressed images which at least give us a sense of what that ligamentous structure looks like. So again, soft tissue injury, an osseous avulsion you may fix depending on the bony size, and then if there's laxity then you would just reconstruct. Now moving from the actual injury to things that can predispose, so there's anatomical features that can predispose to patellofemoral instability. It's the patellar position, the trochlear morphology, as well as the patella itself. Now the patellar position is something that has been discussed, and there are about 4,572 methods by which people want to measure differences in patellar position. I will discuss 7,322 of them. No, I'm just kidding. But essentially, people are looking at whether the patella is high riding or down, and then everybody's sort of trying to now focus a little bit more on what is the overlap between the trochlea as well as the patella. So I think here it comes out to take your pick. What do you like? We can measure it and give it to you. So I think that sort of is where we're at. I think people are moving away and not talking as much about patellar morphology at this point in time, but that just depends on when people decide to make it in vogue again, and we'll come back to talking about it. But we can look at the morphology and we can talk about those things as well. This is just from the standpoint of craniocaudal patellar position. When we think about the trochlea, again, the classic de jure classification of trochlear morphology, which should typically be done about 2.5 to 3 centimeters above the joint line, is where you want to look at this. And we can talk about a regular, slightly shallow trochlea. We can talk a very flat trochlea here, as Clement described before, but more arthroscopically. We can talk about somebody who's got a more sort of concave one, and then here we can talk somebody who's got like a cliff-hang deformity of it. So we can tell this morphology on MR, you can tell it on CT as well. What I find nice about MR sometimes is, and I've noticed this a few times, not many times, but sometimes the morphology that you see from the osseous component and you see from the cartilaginous component will vary a little bit, and I think that's sort of something interesting to look at in some of these cases. And therefore, I have on occasion even put out on a report saying the bony morphology conforms to like a de jure B, and then the cartilaginous morphology conforms to something slightly different. And then, as we discussed, trochleoplasty is something that people would consider here. There's obviously a large number of patellofemoral measurements that one can use, everything from a trochlear angle, asymmetry, trochlear depth, and a whole host of these, which can be measured on MR using some fairly standardized techniques. I think the only thing, again, when I get phone calls from orthopedic surgeons specifically requesting one measurement and hopping on it, we used to have an old saying in radiology, which was, there's nothing more dangerous than a radiologist with a ruler. I think there is one thing more dangerous, which is an orthopedic with a surgeon with a ruler, because they actually do something. We're just sort of, throwing around words. So I think this is just, and I think this has come to light with what everybody said. I think patellofemoral instability is a relatively complex issue. It's an interplay between osseous and soft tissue structures. And so while, yes, the bony measurements are important, I think it's important for you to look at the soft tissue, the patient as a whole, and the alignment before you take a call just based on measurements. So other things in terms of surgical decision-making things that we look at, the TT-TG distance. Now, we discussed this. We can do this on MR very easily. We can put an arcade where you can overlay the two structures, the tibial tuberosity and the trochlear groove, and we can get you the TT-TG measurements. But as I've mentioned before, there is an enormous amount of variability that we've noticed in TT-TG measurements. When we look at patients, even when there's the same patient is scanned twice using the same modality, there's a fair amount of variability with just rotation. So one of the things that we recommend, or that's traditionally said, is that people should keep their toes up. It's sometimes difficult to ensure that technologists do this on a consistent basis. When people go into an MRI scanner, as mentioned before, there is a certain degree of flexion. There's also a certain degree of packing that we do. So we get people into an MRI coil, we put packing material around them to make sure that the knee doesn't move, and this will also change alignments. And this would actually become far more relevant in people who have lax knees. So somebody who has a fairly solid knee, you probably wouldn't have much of a change. And somebody who has a lax knee, you would see a very, very significant change when you do and do not have packing, when you do and do not have degrees of flexion. So in fact, that variability is something that you should be very aware of, and I think that's where your clinical intuition as to whether there is really an element of laxity or malrotation becomes very, very important. Excessive valgus is something, so in our practice, I think Bhushan does a lot of the work in our practice, and where we look at excessive valgus, I think that's something we get scanograms on very often, do the measurements for your LDFA, and I think the decision making is something that is, definitely not in the syllabus that I studied, but somewhat. But essentially, you could pick between medial closing osteotomy, such as this patient. Here's another patient who had a lateral opening osteotomy because they wanted a little more length and some derotation component to it. And this is one who had very, very excessive valgus, and they decided to go with both a medial closing and a lateral opening osteotomy. So scanograms do play a role in your assessments and management of this. So what I've tried to sort of do is, during this talk a little bit is, and I know we have time, but we can have time for questions, is I've tried to talk about what are the structures that are affected. So we think about the three structures that get affected most often when you have patellofemoral instability. That involves the patella, the trochlea, and the patellofemoral ligaments. If we think about the patellar position, TT-TG distance, and rotational alignment do not typically get affected when you get a patellofemoral dislocation event. They're just sort of predisposing areas. The predisposing factors are almost all of these. So you could have, for now, we're not very excited about patellar shape, but maybe we will be. Definitely excitement about the trochlear morphology. The status of the patellofemoral ligaments, whether they're developmentally or acquiredly abnormal. The patellar position in the craniocaudal plane direction, the TT-TG distance, and the rotation and alignment are all supposedly predisposing factors. And when it comes to managing, obviously now that Clement described again, trochleoplasty is something that some people go more towards. But otherwise, all the structures fall into the category of which could be potentially manageable. And on radiology, we can give you information about all of these structures that can help you in that decision-making process. But I would warn against purely using imaging to make your decisions. A quick word on patellofemoral friction syndrome. This is something we see fairly often in the young population. One of the ways that we identify, and just to be, I guess chondromalacia patella is the other situation that we always talk about with patellar cartilage changes. But patellofemoral friction syndrome is something we raise the possibility of when we see, especially in the lateral infrapatellar fat pad, we see some soft tissue edema. Again, this is not 100% thing. Just seeing edema does not mean that somebody has patellofemoral friction syndrome. I will often end up mentioning it in situations where I find nothing else in the scan, or they give me very clear insight that somebody's got a patellofemoral problem, and I would mention that. There are some people who talk about, and I think a lot of this is clinically assessed, but we do occasionally get situations where people want us to look at patellofemoral tracking. And we can do this by CT or MR by taking them in various degrees of flexion and seeing at what point the patella sort of subluxes out and what point it flips back in. So these are two things that we end up doing for patellofemoral friction or tracking situations. So what I've tried to do in the last 13 minutes or so is talk about what does patellofemoral instability consist of? Two components, primarily just dislocation events, and secondly, tracking and instability issues. When I think about dislocations, I think about imaging being able to tell us the effects of a dislocation event on the patella, on the trochlea, on the patellofemoral ligaments. I think about what are the predisposing factors to patellar instability and how we can give you information on those. And then I sort of think about what are the surgically important things that you need to know when you're trying to manage patients with patellofemoral instability. Again, just putting a warning out there that don't just go with the measurements. There's a lot more to it than that. And then when it comes to patellofemoral tracking issues, infralateral patellofemoral fat pad edema, and then sometimes just in terms of looking at patellar tracking. So I'll stop with that, and if there's any questions or concerns.